Today we'll go through how to take a complete diabetes mellitus history. The important point is this. Diabetes history is not just about asking the latest sugar value. A good history tells you about control, treatment, complications, safety, function, and the patient's real ability to manage the disease. So when you see a patient with diabetes, don't stop at HbA1c. Think wider. Are they having high glucose symptoms? Are they having low glucose episodes? Are they taking treatment correctly? Do they already have eye, kidney, nerve, heart, brain, leg, or foot disease? And finally, is there something in their life making control difficult? Use the same sequence every time. Start with the patient's agenda, then background, control, treatment, low glucose episodes, complications, foot disease, risk factors, social history, and then the plan. This structure keeps your history complete, but also clinically useful. Always start with the patient's agenda. Ask, what brought you today? In diabetes, the presenting issue may be poor control, recurrent low glucose, a foot ulcer, visual loss, or difficulty using insulin. If you start with the patient's priority, the rest of the history becomes much more focused. Next, define the diabetes. Ask whether it is type 1 or type 2, the age at diagnosis, and the duration. Duration matters because complication risk rises with time. Family history also matters, especially if diabetes started young or affects several generations. Then look for clues to the type of diabetes. Is the patient obese or lean? Was there ketosis? Is there an autoimmune background? Did they need insulin early? Is there young-onset diabetes in the family? This step is important because not every patient neatly fits type 1 or type 2. Now, assess current control clinically. Ask about thirst, polyuria, nocturia, weight loss, fatigue, and blurred vision. These symptoms are simple, but they often tell you that the patient is currently poorly controlled even before you look at the lab results. Also ask about infection clues. Recurrent skin infection, boils, abscesses, balanitis, vulval itching, fungal infections, or urinary infections may be the clue to poor glycemic control. In clinic, infection is sometimes the reason diabetes is discovered or reviewed. After symptoms, move to the glucose pattern. Don't accept one random reading. Ask about home glucose monitoring or glucose sensor trends. What are the fasting values? What happens before meals, after meals, at bedtime, after exercise, and after insulin? Pattern matters more than one number. Then, interpret the HbA1c carefully. It gives you average control, but it does not show glucose variability. A patient may have a high HbA1c and still be having frequent low glucose episodes, so always interpret HbA1c with symptoms, glucose records, and treatment history. Ask about acute metabolic complications. Has the patient ever had diabetic ketoacidosis? Have they had hyperosmolar hyperglycemic state? Have they been admitted with uncontrolled diabetes? These events suggest severe instability, treatment mismatch, intercurrent illness, or gaps in education. Now review insulin practically. Ask the type of insulin, the regimen, the dose, the timing, and how it relates to meals. Ask about missed doses and who adjusts the insulin. A clear insulin history can often explain poor control before any investigation does. Technique is just as important as dose. Ask where they inject, whether they rotate sites, how they use needles, and whether there is lipohypertrophy. Also ask about insulin storage. Poor technique can mimic treatment failure, so never assume the problem is only the dose. Then review non-insulin treatment. Ask about tablets and injectable drugs. Name, dose, duration, response, side effects, adherence, and affordability. In real practice, treatment failure may be pharmacological, but it may also be due to side effects, cost, misunderstanding, or irregular use. Ask about education and lifestyle. Has the patient received dietary advice? Do they exercise? Do they understand self-monitoring? Have they had structured diabetes education? For type 1 diabetes, ask about structured insulin education such as DAPHNE if relevant. Education improves both safety and control. Now, come to low glucose episodes. This is a major safety question. Ask how often they occur, what time of day, and what triggers them. Missed meals, insulin timing, exercise, alcohol, and kidney disease are common causes. Also ask about warning symptoms and nighttime episodes. Then ask why low glucose matters clinically. Has the patient lost awareness? Do they need help from someone else? Have they collapsed, had a seizure, fallen, or been injured? Do they drive or work in a safety-sensitive job? Remember, high HbA1c with repeated low glucose usually means unstable control, not safe control. Now screen for large vessel complications. A simple way to remember this is heart, brain, and legs. These complications drive much of the morbidity and mortality in diabetes, so they should be actively asked about, not left until the end. For coronary artery disease, ask about chest pain, exertional angina, breathlessness, orthopneumonia, paroxysmal nocturnal dyspareunia, and ankle swelling. Also ask about previous myocardial infarction, angioplasty, stents, or bypass surgery. Diabetes can present with atypical or silent ischemia, so ask actively. For cerebrovascular disease, ask about previous transient ischemic attack, stroke, focal weakness, speech disturbance, and visual disturbance. Also ask what deficits remain. Don't just ask whether a stroke happened. Ask how it affected function. For peripheral vascular disease, ask about claudication, rest pain, cold feet, color change, and non-healing wounds. Ask about previous angioplasty, bypass, stenting, or amputation. In diabetes, foot problems are not always neuropathic. Always think about ischemia as well. Now move to small vessel complications. The memory structure is eyes, kidneys, and nerves. These problems may progress silently, so you must ask about both symptoms and previous screening. For eye disease, ask about blurred or worsening vision, floaters, last retinal screening, previous laser treatment, intravitreal injections, or eye surgery. Also ask about functional impact. In diabetes, normal vision does not exclude retinopathy, so screening history is important. For kidney disease, ask about albuminuria or proteinuria, creatinine, kidney function, swelling, fluid overload, blood pressure control, and nephrology follow-up. Kidney disease increases cardiovascular risk and can also increase the risk of low glucose episodes because insulin clearance may fall. For neuropathy, ask about numbness, burning, tingling, pain in the feet or legs, reduced sensation, and the classic feeling of walking on cotton wool. Then ask about autonomic symptoms, postural dizziness, gastrointestinal symptoms, bladder symptoms, and sexual dysfunction when relevant. Never skip the diabetic foot history. Ask about previous or current ulcers, wounds, pain, redness, swelling, discharge, or fever. Ask about footwear, barefoot walking, self-inspection, podiatry review, neuropathy, ischemia, previous debridement, amputation, or revascularization. A complete foot history covers ulcer, infection, neuropathy, ischemia, and self-care. Then step back and assess risk factors. Ask about hypertension, treatment adherence, hyperlipidemia, recent lipid review, and smoking. In women, ask about pregnancy-related diabetes where relevant. Also ask about young-onset diabetes in the family and family history of cardiovascular disease. Risk factor control changes prognosis. Now consider secondary or associated causes, especially when the phenotype does not fit. Ask about pancreatitis, cystic fibrosis, hemochromatosis, Cushing's syndrome, acromegaly, pheochromocytoma, chronic liver disease, infections if relevant, and transplant history. These causes may change treatment and follow-up. Finally, ask why control may be difficult in real life. Review drugs that can worsen glucose, such as glucocorticoids, thiazide diuretics, atypical antipsychotics, tacrolimus, and HIV protease inhibitors. Beta blockers may reduce awareness of low glucose symptoms. Then ask about alcohol, work pattern, finances, affordability, disability, vision, mobility, driving, mood, support at home and family planning where relevant. Poor control is not always non-adherence. Sometimes it reflects barriers. End with a plan. Explain the importance of good control, reinforce education and self-monitoring, review diet and exercise, set realistic goals, arrange eye, kidney, and foot screening, and safety net low glucose episodes. So the final sequence is agenda, background, control, treatment, safety, complications, risk factors, social function, and plan. That is how a diabetes history becomes not only complete, but clinically useful.